we're going to talk about the skin infection or skin area of the PCCM, starting with bacterial skin infections in adult or child. Be vigilant for Group A strep, which is particularly common in the Northern Territory or Aboriginal and Torres Strait Islander communities. Group A strep can lead to post-strep glomerulonephritis or acute rheumatic fever if left untreated. If skin infections are caused by foreign body, fish spines or marine creatures, see a different section. Treat bacterial skin infection first if coexisting with scabies or other skin condition. The majority of bacterial skin infections in affluent communities are due to Staph aureus, less commonly Strep pyogenes. In some locations, such as remote Aboriginal and Torres Strait Islander communities, Strep pyogenes is often the primary pathogen. If infection is due to Strep pyogenes, glomerulonephritis may follow within 8 weeks, plus other infectious disease complications such as acute rheumatic fever, scarlet fever, streptococcal toxic shock syndrome, pharyngitis and pancreatitis. Related topics for this area are all of these. Impetigo in an adult or child, this is school sores. So review in 2 weeks and check blood pressure and urinalysis if antibiotics have been given for impetigo. Mupirocin 2% skin ointment should be restricted to mild impetigo. Non-remote settings, mupirocin intranasal ointment may be used for those with recurrent staph infections, essentially for eradication of staph, but you want to do nasal and perineal swabs before that, I guess. Impetigo is highly infectious and it occurs primarily in school-aged children. It can lead to serious systemic complications from streptococcal skin infection, including acute post-strep glomerulonephritis and ARF. May complicate pre-existing skin conditions such as scabies, eczema, tinea, insect bites and minor abrasions. So generally it presents as a small vesicle, maybe a tiny blister, sometimes with surrounding zone of erythema that gradually becomes pus-filled. The vesicles and pustules rupture easily. The discharge dries, forming a thick, soft golden yellow crust, which is the hallmark of impetigo. It can also present with itchy, irritable lesions, not painful, and individual lesions rarely exceed 2 centimeters. Sometimes you can get satellite lesions and these can join to form larger lesions. You want to get a complete patient history, and that this is something discussed earlier in this section of the PCCM. Standard OBS, weight, urinalysis as baseline data, maybe for evaluation of any further post-acute strep glomerulonephritis, physical exam, and you want to see the assessment examination of skin, hair and nails, which is listed up here. We can just read through quickly here. Essentially everything. So anything beyond simple impetigo or school sores, you might want to contact your MO. If your blood pressure or urinalysis is abnormal, because that may indicate the presence of acute post-strep glomerulonephritis. They're systemically unwell, so I guess a lot of impetigo and cellulitis can progress to sepsis. If they have a fever, so cellulitis or erysipelas, which is essentially cellulitis on the face. If there's recurrent infections in the individual or family, that's when to consult an MO. If you've got mild isolated cases, you can remove the crusts and debris by soaking in soap and tap water. You want to make sure you wash all those clothes and dry in direct sunlight and emphasize personal hygiene. In severe widespread cases, you want to take a swab from the lesions, commence orals. Until culture results are available, suspect Staph aureus. And things that are active against Staph aureus will usually generally cover Strep pyogenes. In situations where Strep pyogenes is confirmed or suspected, use penicillin as a first choice if not allergic. Advise the parent impetigo is highly infectious and the child should exclude themselves from contact with others for at least 24 hours. And you must cover the sores with a watertight dressing. In terms of medications you can use, there's phenoxymethyl penicillin. Comes in capsules or tablets. Oral. Usual dose is 500 milligrams QID or 12.5 mg per kg dose for a child for 10 days. If lack of observance with oral medicine is anticipated, you can try treating with benzopenicillin, given IM at the doses listed here. So for 20-year-old person, 900 milligrams of benzathine penicillin. Severe and widespread recurrent infections. Think about Diclox orally for an adult, 500 milligrams QID, 10 days. Fluclox, similar deal, 500 megs QID or 12.5 megs per keg. Or if you've got a hypersensitivity to penicillin, you can use Keflex. 1 gram BD, which is kind of similar to 500 QID, isn't it? Or 25 megs per keg BD, which again is similar to 12.5 megs per keg QID. So you want to give that if there's hypersensitive penicillin but not an immediate hypersensitivity. Or if there is an allergy to penicillin. Now, I'm not sure how correct this is. I didn't think there was a cross-reactivity between the two. However, this is what it says. Clindamycin, 450 megs TDS for adults or 10 megs per keg TDS for children. There's no liquid, however you can make a solution by dissolving the capsule in water. Or if there's allergy to penicillin and it's more practical than dissolving a tablet, or if you've got multiple parents or family members being treated, you want to think about trimethoprim sulfamyxyl, that one. Bactrim essentially, isn't it? And for mild impetigo, use a mupirocin 2% ointment. Follow-up, review daily. If antibiotics have been given, you want to do that follow-up for post-strep, glomerulonephritis or rheumatic fever.